Hello, I'm Katie Cottingham from the American Chemical Society. Welcome to the first news briefing from the ACS Fall 2020 Virtual Meeting and Expo. We're joined today by Dr. Cody J. Wenthur and Dr. Jillian Kyzer from the University of Wisconsin-Madison. They're studying negative effects of opioids that could be coming from the user's own immune systems. Dr. Wenthur?
Good morning. As Katie said, I'm Dr. Wenthur. I'm assistant professor at the University of Wisconsin. On behalf of myself, my co-author Jillian Kyzer, our collaborators, and our funders at the ALSAM Foundation, I'd like to briefly introduce our latest work. This study focuses on identifying antibody responses to chronic opioid use. Dr. Kyzer will be presenting this work as part of the Fall 2020 ACS meeting in both on-demand format and at the CIMEX event. So hundreds of millions of opioid prescriptions are filled each year in the United States. These compounds are used for their pain-killing properties and do often provide substantial quality of life improvements for patients when they first take them. But with these benefits also come risks, including the risk of dependence and fatal overdose. Advance the slide. Unfortunately, the benefits of opioid use tend to wane over time while the risks generally increase. Tragically, the opioid epidemic continues to kill tens of thousands of American citizens every year. Advance the slide. This ongoing public health crisis makes it important to identify ways to improve opioid safety, such as reducing the average time that patients are on opioids. Next. Or finding new therapeutic approaches, such as vaccines against opioids. Next. And advance the slide, please. In order to help support these strategies and turn the tide of the opioid overdose epidemic, we aim to understand factors that influence their likelihood of success. Extremely idea that long-term opioid use might cause formation of modified self-proteins and an anti-opioid antibody response. Sorry, lost the lights here. If the antibodies are found, they could contribute to even more inflammation and pain and indicate that a patient would be especially likely to benefit from switching off of opioids. Additionally, these anti-opioid antibodies could serve as markers for predicting whether a specific patient would be more or less likely to benefit from an opioid vaccine. Slide, please. And one more time, and then we'll move to the next slide. To look for these anti-opioid antibodies, we generated synthetic opioid protein conjugates that would serve as bait and used these bioconjugate lures to test blood samples from patients who had chronic back pain. Most of these individuals had been taking opioids for years to treat their back pain, but we also recruited a few individuals who had not been using opioids at all. Advance the slide. As we hypothesized, our bioconjugate lures were able to hook antibodies in some of the opioid-exposed patients, but not in the opioid-naive samples. Importantly, we also found that there was a relationship between the strength of the antibody response and the dose of opioid that each patient had been taking recently. Advance the slide. And one more time. Patients taking higher opioid doses were found to have higher concentrations of anti-opioid antibodies. This suggests that recent exposure to opioid molecules is a relevant factor in the formation of this immune response. We're now working to identify the mechanism by which these antibodies are formed and plan to assess a larger population of patients to see if this observation holds up across a broader sample. Last slide, please. Thanks for taking a few minutes to let me introduce the work. We're very excited to share these findings with you today and hopeful about what they may mean for reducing opioid-associated harms. We're now happy to answer any questions that you might have about our study.
Thank you. So are there any questions from viewers? If you do have a question, please state your name and affiliation in the chat window when you ask your question. I'll start off the questions here. So why don't all opioid users develop these antibodies?
That's a great question, and it's one that's germane not only to our findings, but to the development of the vaccine as well. And the answer right now is not 100% known, but we think that it has to do with differences in individuals' immune systems and their ability to generate responses to external threats. We all have different levels of response to different immune insults, this being one particular class of immune insult.
Okay. And does the immune system make antibodies to other types of drugs too? Or is there something specific about the opioids?
Sure. So normally your body does not make antibodies against small molecules. There are other small molecules such as methamphetamine and nicotine, particularly a metabolite of nicotine, nornicotine, that have been shown to generate antibody responses. But this is relatively unusual, and our finding with opioids is among few showing responses to small molecules. Other small molecules such as penicillin, or if you think of poison ivy, the compound of that is urushiol, will actually react with your proteins and cause an immune reaction as well. But with medications, this generally doesn't happen to most patients.
Okay. Okay, and we have an online question from Laura Cassidy, American Chemical Society. Did those with antibodies have chronic inflammation and heightened pain sensitivity, and those without the antibodies not have those negative side effects?
It's an excellent question, and one that we're deeply interested in following up on. We did survey the individuals regarding their pain history and their efficacy of their opioids over time. We did not identify in this sample any individuals with a diagnosis of what's called opioid-induced hyperalgesia, or a really elevated sensitivity to what would normally be a non-painful stimulus. But these individuals do exist. It's a known side effect, and it would be very interesting for us to follow up and see if the antibodies correlate with these hyperalgesic outcomes or other negative outcomes of long-term opioid use.
Right. And so you mentioned opioid vaccines. Can you explain those a little bit to us?
Sure. Jill, do you want to take a go at that one?
Sure. So there are a variety of groups who are currently working to make opioid vaccines. Our collaborators, in addition, are one of the groups that are working on it. And so basically, you take a protein like a tetanus toxin or something that's used for a variety of different vaccines. And just like we made our lures to bring in order to evaluate the samples themselves, you attach the opioids to those proteins and then give them in a vaccine the way you would give a vaccine for flu or for potentially COVID. So it's a pretty exciting field. And so a lot of these studies are currently in clinical trials, I think phase 1 or phase 2. Mm-hmm. So, you know, I guess be on the lookout for that data in the coming year or so.
Great. And we have a question again from Laura. If antibodies against opioids can produce negative effects such as inflammation and pain, does this bode well for opioid vaccines?
Yeah, so this is a complicated issue. There is absolutely an intersection between the propensity of individuals to develop antibodies and the ability of the vaccine to do its job. What we were looking at in our study here are what's called IgM antibodies, excuse me. There are a few different types of antibodies that your body can make, and they have different roles. The IgM antibodies are the first responders, and they are generally weaker in terms of their ability to bind or attenuate immune insults that come in. What a vaccine will make are called IgG antibodies. And these are the high affinity memory antibodies that can be recruited time after time if you have an immune insult. And so there are intersections between development of the IgM antibodies and subsequent development of the IgG antibodies. A notable example of this is with a previous clinical trial of an anti-cocaine vaccine, patients who had higher levels of IgM antibodies, which is analogous to what we saw here, actually had a poorer response to the vaccine. And so this may be a negative efficacy biomarker for individuals who would otherwise be qualified to receive the experimental opioid vaccine.
Okay. And you mentioned, I think that there was some sort of group that probably was attached to the opioid. So have you found what that group is, and is that causing the issues of the side effects, or is it just kind of a combination?
Jill?
So the group that's attached to the opioids, we were initially investigating the role of glucose in this process, as these carbohydrates have been shown to participate in similar reactions. But in our initial studies, we were able to show that glucose is probably not the likely, culprit. And so we do need to do further studies in order to look at other sugars that are found in the body, like ribose, for example. So.
Okay.
Yeah, the degree to which the what we're calling advanced glycation end products, or the hapten themselves, is responsible for negative outcomes versus opioids is still, versus the antibodies against the opioids is still certainly an open question. And as Jill said, we have some mechanistic hypotheses about what to follow up on.
Okay. Let's see. And so could you use the knowledge from this project to help those who are experiencing those side effects? Is there some way to then give them a therapy to reduce those?
I think one of the biggest implications for this potentially could be something I alluded to in the introduction, which is these antibodies may be a marker of therapeutic failure for the opioids themselves. And so to harken back to the hyperalgesia question, that's only one of several negative outcomes that could occur, right? One of the other negative outcomes that occur is just increasing doses of opioids while having reduced efficacy, for example. And so these antibodies could point to and provide support for physicians and other healthcare providers to help their patients transition off of opioids and onto other long-term pain treatments that we know have better risk-benefit profiles over the long term, such as non-steroidal anti-inflammatory drugs.
Okay.
So I have, a follow-up there. So I guess one thing that we noticed, right, was that it was the recent daily dose that was correlated with the response. And so there are a variety of opioids themselves that aren't structurally related. And so one potential outcome could be that, if someone, needed to be on opioids long term, switching between these unrelated opioids, for short periods of time could be more helpful than, for example, staying on hydrocodone or oxycodone for 20 years.
Right. Okay, and how long do the antibodies to opioids persist after a person stops taking them?
Sure. So Jill mentioned that we use a protein conjugate to the opioids to fish for these antibodies and also to help generate the vaccine. That induces an immune response that lasts anywhere between 3 to 6 months in primate studies. We're not certain how long that response lasts in humans yet. The clinical trials that others are undertaking will certainly help answer that question. So we would expect, given the mechanism by which we think that this occurs, that the duration of antibodies being generated by simply taking these opioids chronically long-term would likely last for a similar time frame. We're probably talking about 3 to 6 months.
Okay.
To follow up on that just briefly, as Jill mentioned, the dose response correlation was only with recent dose and not with lifetime dose. And because of this turnover in opioid antibodies from 3 to 6 months, that's likely why we don't see a correlation with lifetime dose, because it needs to be reprimed on that order of time scale.
Got it. Okay, and what are your next steps for this research? Like, what is the very next thing that you plan to do?
Yeah, the very next thing that we plan to do is try and find these opioid protein conjugates that we think are actually creating the antibody themselves. So Jill can talk about the experiments that we're doing with Western blot, et cetera, to try and find those.
One thing would be to try and run patient samples that have antibodies, and try and, I guess, and then use a purified opioid antibody in order to provide the same signal that we see in the ELISA experiments, but you can see like what proteins have the opioids attached to them, use it in that process. So that's a pretty interesting one, which should be and has been shown for like nicotine, for example, in smokers. So.
And I think the other thing that is very next on our docket is trying to find more individuals who hadn't been taking opioids to confirm that we don't see these in those patients. We were only able to find 3 of those patients despite, a citywide search for using radio and print campaigns. So that goes to show you the ubiquity of use of opioids in chronic pain, for one thing, but it also highlighted a challenge to us of trying to find and needing to expand on that control group to make sure these results hold up.
Right. Okay, let's see if there are any other questions. I don't see any more. So thank you very much for joining us. The archived version of this session will soon be posted at www.acs.org/fall2020 press conferences. Please join us for our next press conference at 10 a.m. Eastern today on an immunotherapy that extends survival in a mouse model of hard to treat breast cancer.